Vogely. I'm the Manager of State Affairs at AOTA, and I want to welcome you to AOTA's webinar regarding occupational therapy and telehealth. Tonight, I want to go through some of the updates regarding legislation and regulation concerning occupational therapy and telehealth, as well as discuss some of the policy trends that we are seeing. I want to explain AOTA's position on the policy trends in the hope that it helps you, the regulatory bodies, if and when you choose to create regulations or legislation. At the end of the presentation, there will be a Q&A session. If you have a question, please click on the raise hand feature at the top of your screen. It looks like a little person with their hand up, and Jeremy or I will open up the line so you can ask the question. I also want to mention that this is being recorded and it will be available for you to download later. If you didn't call in, you wouldn't be able to do the raise hand feature and ask the question. So if you didn't call in and you do have a question, you can type it in the chat box at the bottom and we'll make sure to get to it. All right, let's get started. So if you haven't already seen it, AOTA does have a position paper regarding OT and telehealth. You can find this on our website or you can email me and I'll send it to you. While AOTA's position on the use of telehealth to deliver OT services is clearly more detailed than what this slide presents, these are the two main tenets of the position. Occupational therapy practitioners can use their clinical reasoning to determine whether telehealth is appropriate, and they must adhere to the Code of Ethics and Standards of Practice, as well as any federal and state laws and regulations. AOTA does feel that a telehealth service delivery model increases accessibility to clients in remote and underserved areas, improves access to providers, and prevents unnecessary delays in receiving care. Telehealth has the ability to be used as a service delivery model in each major practice area within OT, and I'm sure, as you well know, there are lots of them. So I want to talk a little bit about clinical reasoning, and this comes straight from the position paper and describes how we view clinical reasoning. I want to highlight that we feel that telehealth is a way to deliver services, not a modality or a service in and of itself. I realize that there is a basic concern of, well, what if telehealth isn't appropriate? But again, it's letting the clinician decide whether or not it would be appropriate. Sometimes telehealth isn't appropriate to deliver a service or perform an evaluation, but we feel it should be up to the clinician to decide this. And throughout this presentation, I'm going to sort of be harping on this and talking about it over and over again, because we do feel that it should be up to the clinician. All right, so this is a list, and it's also from the position paper. And it describes the things that clinicians should take into consideration when determining whether or not telehealth is appropriate. It's not an all-inclusive list, but it certainly gives a clinician an idea of what to look for. So these would include the complexity of the client's condition, the knowledge, skill, and competence of the occupational therapy practitioner, the nature and complexity of the intervention, the requirements of the practice setting, the client's context and environment, and the client's comfort and competence with technology. So in addition to the position paper, AOTA also has a paper regarding telehealth and ethics. Again, if you haven't seen this paper, it is on our website, or email me and I can send it to you. This list is from our ethics paper regarding how clinicians should use telehealth in an ethical sense. For instance, the first bullet, inform the client about the implications of telehealth versus in-person delivery model. This pertains to ensuring that the client fully understands that telehealth is a different service delivery model and requires some knowledge of the technology. We would want patients to know that they should feel comfortable with the technology before delivering the service using that technology. Again, it's not, you wouldn't ask somebody who, has never used a computer before, for instance, to go ahead and write, a 40-page essay and all that. So in addition, it is essential that the services delivered, no matter how they are delivered, are in line with professional standards and practice guidelines. Clinicians should also follow HIPAA and ensure that privacy, security, and confidentiality are not compromised, and adhere to any procedures in case something is compromised. As always, clinicians need to be aware of the effectiveness of interventions and be up to date with current research, especially with telehealth. Lastly, it is always important for the clinician to be culturally competent, whatever the service delivery model is. I want to quickly give you some terminology for some of the telehealth modalities that you'll see. In the telehealth world, like the American Telemedicine Association, they use the term modalities for the different ways that you can deliver telehealth. First would be synchronous technologies. This would include things such as a live video or even a phone call where there is a real-time interaction that is happening, but it's not in the physical presence of the patient. Next, asynchronous technology would be when something is stored and then sent to the clinician. This could include the patient taking pictures and then emailing them to the clinician, or the clinician giving a patient an electronic questionnaire to fill out as part of the evaluation. Remote patient monitoring is the term used to describe when a patient is sending medical data to a clinician. It's not necessarily synchronous or asynchronous. It's simply they're in another place than you are, or the clinician is, I should say. And mobile health is essentially the usage of mobile apps to conduct remote patient monitoring. There's a lot of technology out there. A lot of apps are popping up to aid practitioners. I was just at the American Telemedicine Association conference, and there are a lot of companies out there that are really utilizing apps to conduct telehealth, and it's pretty awesome, actually, what is now available. All right, so now on to the fun stuff. The next few slides, I want to go through the regulatory landscape, the current situation, future developments in the states, and describe the policy issues and trends, and give you a few examples of what states have done. So here's the current situation. 6 states have telehealth access in the OT Practice Act, but have not created regulations. And there could be many reasons for this. So these include Colorado, Connecticut, Delaware, Illinois, Kentucky, and North Carolina. And just to note that Wyoming updated the OT Practice Act last year, and that included an amendment to add a definition of telehealth, but actual access to telehealth, as well as any other guidance, is still missing. And when I say telehealth access, I mean something that explicitly states OTs are able to utilize telehealth to deliver services, not just, an insurance parity law or something of that nature. 8 states list OTs in statute other than the OT Practice Act. So these could be overall telehealth access acts, and these include Idaho, Louisiana, Minnesota, Mississippi, Nevada, New Mexico, and Tennessee. And in Missouri, they actually have it in regulation, not in statute, but there is sort of a telehealth access bit in regulation. 6 states have created regulations regarding telehealth and occupational therapy, and these include Alaska, California, Delaware, North Dakota, Oregon, and Texas. 4 states have issued guidance, and this can be in the form of an official document, or it was just documented in a board meeting minutes, or just stated on the website. These states are Arkansas, Maryland, Ohio, and Virginia. And 10 states have stated that nothing prevents OTs from providing services via telehealth. These include Alabama, DC, Kansas, Nebraska, New Hampshire, New York, Oklahoma, South Carolina, South Dakota, and West Virginia. In terms of what is happening in the near future, many states are working on either ensuring legislation or regulation. Kentucky recently proposed regulations, withdrew them, and I believe will be reintroducing regulations this year. Iowa also recently introduced regulations, and the board will be reviewing comments this week. Georgia, Idaho, and Washington have stated they are working on developing regulations for telehealth. And in fact, today I got the preliminary regs for Idaho, so they are actively working on them. And Nevada and Wyoming are potentially going to be working on regulations. And I believe that in Montana there was talk about a telehealth bill, but it didn't get off the ground. In Utah, there was an attempt to add OT to the list of telehealth providers. And in Michigan, they may be introducing legislation. That's something they're talking about currently. In Nebraska and West Virginia, they're thinking about not going in the legislative or regulatory route, but instead using board guidance that addresses telehealth. And if I missed anyone, please email me after the presentation. Let me know where you are in the process. Currently, there's a lot of fast-moving developments regarding policy with telehealth and OT, but there's also a lot more work to be done. And AOTA encourages all states who are considering developing any policy to work with us and other stakeholders in order to develop regulations that meet the needs of protecting the public safety and moving the field forward. And I just want to mention, when it comes to developing regulations especially, it is a good idea to reach out to the stakeholders before starting that promulgation process. Just like with the Idaho board, they haven't started the promulgation process. They sent us the preliminary proposal so that we can take a look at it, offer informal comments beforehand. And this would help with the promulgation process. It certainly shortens it because the board can take into account all the all the comments beforehand, make any changes that are necessary. So just my 2 cents on the regulatory process. So when a state proposes regulations for telehealth, AOTA reviews them and looks for specific aspects of the regulations. I want to go through the main aspects that we look for and what we're looking for specifically. This is a summary list, and I'm going to go through each one in detail. So the first issue that I want to discuss is the idea of interstate versus intrastate for telehealth. Interstate would be whether the clinician could be located in another state, but still licensed in the state where services are being delivered. Intrastate would mean that the clinician must be physically in the state where services are being provided, even though they may be still using telehealth. I want to point out that the two terms, I want to also point out real quick the two terms that show up a lot in law and regulations. First, originating site. This is the term that's used to describe the location as the patient, and distant site is the location of the clinician or the provider. And AOTA feels that in order for telehealth to be fully utilized, states should ensure interstate activity. This means that the OT could be located anywhere, even in another country, as long as they are licensed in the state where they are providing services. The reason for this being that if you were to limit telehealth to just your own state, you may be creating a barrier to access of care. We want to increase access to care, so if you have more licensed practitioners in your state, that is essentially a good thing. As well, the Federal Trade Commission and certain state courts, which I'll discuss later, have weighed in on the competition aspect and have said that if you limit it to intrastate, you are reducing competition, and that may be a violation of antitrust laws. Another issue that we look at is whether proposed regulations put limitations on the types of services that can be delivered via telehealth. Again, we feel that telehealth is a service delivery model, and it should be up to the clinician to decide whether or not telehealth is appropriate. Putting limits on the types of services that can be offered does not allow for freedom for the OT in using clinical reasoning. For example, if the state decides that an occupational therapist must be in the physical presence of a patient if a DME or some other kind of device that involves skin-to-skin contact is involved, this could have a lasting impact. If a patient were to call an OT about pain, the OT potentially would not be able to tell the patient that they need an ice pack due to this kind of regulation. There are also instances where you could have an OT at a distant site and an OTA at the originating site with the patient. The OT could direct the OTA, but if you limit the types of services, that's a pretty restrictive regulation, and even this kind of service delivery would not be allowed. Again, I want to point out that AOTA feels it should be up to the OT whether or not they think telehealth can be used, a good regulation would be broad enough to allow this. So it, and I'll probably talk about this a lot, but again, when we're talking about creating regulations, it's good to have some broad language as opposed to something very specific and restrictive, just because things can change and the restrictions, can really restrict clinicians' ability to just be able to provide services in general. Evaluations. So some states have proposed or enacted regulations requiring that the evaluation be in person, specifically the initial evaluation. And it's a pretty hot topic when it comes to telehealth. Many regulators don't know how it would be possible to conduct an evaluation via telehealth. And when I say regulators, I don't just mean with occupational therapy, I mean with lots. I look at legislation, regulation for all the professions almost. But so it's kind of the same concern in physical therapy, not so much in speech therapy, but, where other professions are conducting telehealth. But in terms of OT, I can tell you that there are OTs who are currently utilizing telehealth and are currently conducting evaluations using telehealth. Again, I want to go back to the whole clinical reasoning aspect. You let the OT decide what's appropriate. As well, the Federal Trade Commission recently weighed in on regulations in Delaware that restricted the use of telehealth for evaluations, stating that it may reduce competition. Again, AOTA feels there should be no restrictions on whether or not the evaluation should be in person. You'll let the OT decide. It's all about clinical reasoning, and by restricting it, it could be a barrier to access of care. With informed consent, AOTA feels that lengthy regulations regarding informed consent are a restriction to access of care. This could include the need to give the patient an additional document that the patient would need to sign consenting to telehealth. Again, AOTA feels that telehealth is a service delivery model, not a service in and of itself. So just simply consenting to having services would be enough. Having that additional layer where you consent to services via telehealth is maybe, excessive. But there are states that have enacted regulations with the informed consent part. So going back to that terminology that I talked about in the beginning, synchronous versus asynchronous. So some states have proposed restrictions on telehealth, limiting it to only synchronous modalities. Telehealth, however, is a combination of both technologies, so restricting it to just synchronous does not allow for it to be fully utilized. Again, I keep harping on this. I warned you in the beginning, but really it goes back to clinical reasoning. You let the OT decide what's appropriate for telehealth. I do want to mention, though, that there are states, for example, Nevada, where Medicaid will not reimburse for asynchronous technologies. However, I'd still recommend not using any restrictive language when crafting regulations as it pertains to synchronous versus asynchronous, even if a state doesn't reimburse, because you never know what will change. And again, using that broad language is generally better, so you don't have to go back and change anything. The healthcare right now is changing a lot, and we just, you never know. Tomorrow you might have something completely different in statute. For instance, in Nevada, maybe they change it, and Medicaid will reimburse for asynchronous. But if the OT regulations say that you can't do it for that reason, then it's sort of counteracting it. With regards to supervision of OTAs, many states do not address how supervision of OTAs works with regards to telehealth. Many have already put in place that supervisory visits must be in person, but AOTA feels that this can move in a direction where remote supervision is possible. We feel that it's not always necessary for an OT and an OTA to meet in person. And I think that with this, if you don't already have the regulations, you don't really need them unless you want to make it clear that OTAs can be supervised using telehealth technologies. I'd also recommend to any state who does have restricted language with regards to supervision to look at that again and determine if it's really necessary. And I wanted to mention too, because I saw the preliminary regs for Idaho, and it wasn't just with telehealth, they also were looking at supervision. And they had, for direct supervision, it said that supervisory visits must be in person. So, but their telehealth regs seem to be pretty broad. But when you have something like that, it's not addressing the supervision of OTAs. But that's in a totally different section, so it could be that, they didn't look at that. So it might be just something to look at, just because, it could be possible. Why not expand businesses and things to have an OT supervising an OTA in a different part of the state? All right, and lastly, we also watch for proposed regulations that would put restrictions on telehealth in terms of treatment versus monitoring. This could be restricting telehealth to only monitoring, for instance. And I haven't seen any occupational therapy boards do this, but I have seen other boards do this. So, what the other boards have said, if it comes to actual treatment, you can't do it. You must be in the physical presence. But if you're just monitoring, keeping up to date with a person's progress, that can be done with telehealth. Again, like I keep reiterating, telehealth is a service delivery model. You'll let the OT decide if it's appropriate, and putting restrictions like this in is a barrier of access to care. All right, so let's talk about some examples. And I don't necessarily want to say that I'm picking on any states. I really just want to give these examples and sort of how AOTA has viewed a lot of these regulations. And as a state, you have the full authority, to craft regulations how you feel is best in your public safety. But with a lot of these, I will mention, just how AOTA views it, how we would come in looking at it. So first up, we have Alaska. And this is this section that is discussing the use of telehealth by occupational therapy. And as you can see in the bolded section, it states that the OT must be physically present in the state while performing telerehabilitation under this section. So this is an example of intrastate, where the OT has to be physically present in the state as well as licensed within the state. And this we definitely see as a restriction. Like I said earlier, we feel that interstate is definitely a better option. And I want to mention, though, even though this is still in the Alaska regulations, in 2016, there was a law passed in Alaska that allows for out-of-state occupational therapists to deliver services in Alaska via telehealth. And I believe that law came about because of a state court decision that said that you can't restrict to just the intrastate. And this was a great victory for occupational therapy and telehealth in Alaska, and we're pretty confident that the regulations will be updated shortly. So here's Delaware. These are the proposed telehealth regulations for Delaware. The Board of OT in Delaware went through a long process with these regulations. I believe it took about 2 years. The original proposed regulations had to be withdrawn and reworked. They included an in-person initial evaluation, and every other visit needed to be in person. Additionally, Delaware had at first proposed that both the provider and the patient needed to be within state lines in order to use telehealth. And after all the long process and all the comments and hearings, it's proposed that this was the final promulgation. The board had chosen to move forward with the requirement for an extra layer of consent. So, even though it's moved forward this way, it's been promulgated this way, AOTA does feel that the regulations are sufficient to meet the needs of the state and the community. And again, I want to take the time to mention, I said Delaware took them 2 years. And again, if you reach out to the stakeholders, that would be AOTA, the state association, the American Telemedicine Association, the Center for Connected Health Policy. These are all the organizations that look for proposed telehealth regs and will weigh in on them. If you reach out to them first and say, hey, this is what we're thinking about for these regs, can you give us some informal comments before we start the promulgation period? We're more than happy to do that. We're happy to work with you on crafting regulations. And this will help in the long run because then you can just move forward. You'll have less formal comments to deal with, and you will have, figured out a really good compromise. well before the promulgation process even starts. It'll just go a lot quicker, I promise. All right, this is the definition of occupational therapy in the Illinois OT Practice Act. Notice how it simply says that occupational therapy may be provided via telehealth and the standard of care should remain the same. That's it. Illinois does not have further statute or regulations regarding OT and telehealth, simply treats telehealth the same as in-person according to the law. And while this is, from AOTA's perspective and many others' perspective, kind of a very simple, easy way of doing this, it could be that a state board might say, well, we do want to have some other clear-cut regulations, that sort of hash out that telehealth is a different type of service delivery model, and these are things you have to take into consideration. But this is Illinois' way of going about it. These are the proposed regulations for Kentucky, which were withdrawn. And this is actually just one of the sections of the proposed regulations. I wanted to highlight these to point out that they are very detailed and therefore could be very restrictive. In general, regulations are there to enact the statute, but these look more like company policies for what to do when using telehealth. I definitely understand that boards need to protect public safety, but sometimes that over-regulation could be a detriment to the profession. AOTA's recommendation for this was to completely withdraw these regulations and replace them with something more broad that wouldn't over-regulate. As well, imagine being a board and needing to check that OTs are doing all of this. How would the board even be able to do that? When crafting any kind of regulations, you have to make sure they're legally defensible. So, with anything, you have to make sure that you can check off all these things. So we just felt like this was too much, and it needed to be much more broad. And North Carolina is another example of a pared down language that simply states that OTs can use telehealth. In this case, North Carolina has added that they must be licensed in the state of North Carolina and needs to follow the regulations of the state, or even, that they have to follow the regulations in whatever state that they're licensed in. This language is in the OT Practice Act and doesn't call for the creation of regulations, so they haven't done that. This is all that they have. And Texas is an example of a state who has put in restrictive language using telehealth. AOTA submitted multiple comment letters regarding this language, as well as ATA, I believe, but the board decided to move forward with the restrictions. So Texas requires that the initial evaluation be in person and that any session that may require a device that would have skin-to-skin contact or skin contact be in person. Both of these regulations restrict access to care in AOTA's opinion. As I mentioned before, the Federal Trade Commission had commented on proposed regulations in Delaware that required an initial in-person evaluation. That was actually with the Board of Nutritionists, I believe, in Delaware. But when the FTC weighed in, they said that if you require it, that may restrict competition and may be a violation of antitrust laws. And they did that actually after Texas had promulgated these. So, I don't know if they're going to weigh in on the Texas ones also, and potentially not since they've already been promulgated. But it is something to think about since the FTC does seem to be getting more involved with board regulations. All right, for the last part of the presentation, I wanted to talk a little about the issues that haven't really been brought up by the boards, but they may be worth considering. First would be with regards to entry-level OTs. I know that I've stated over and over again about allowing the OT to use their clinical reasoning, but I think many people may wonder whether an entry-level OT even has the clinical reasoning to utilize telehealth. A new OT, they've done the schoolwork, they've done their field work, but is that really enough to have developed all that clinical reasoning? So AOTA has some thoughts on that too. AOTA feels that OTs need to recognize their own level of competency and not work outside of that. We do have a paper, which is the second bullet, the specialized knowledge and skills in technology, et cetera, that addresses what level of competency of the, what level of the competency of OT you have and what should be associated with that competency. And you can find this paper on our website or email me and I will send it to you. It actually does have a great chart that shows the difference in techniques that can be utilized for entry-level OTs and mid-level OTs and then advanced OTs. And I want to point out too that the vast majority of entry-level OTs are millennials who have grown up using technology and knows the ins and outs of how to use it. And someone not capable of using it probably shouldn't, but most entry-level OTs will know how. Also, it's important that all entry-level OTs use evidence, mentoring, and continuing education to continue to develop their practice, and this could include the use of telehealth. As I said, no one has addressed this, and maybe there's no need for any kind of regulations, but it is another issue to consider. With regards to training that would be needed to utilize telehealth, there are currently no states who have set standards, but when developing regulations, maybe this is something else to take into consideration. Many school programs do include telehealth, but some aren't teaching about it at all. So you can't necessarily guarantee that a new OT, even if they're a millennial with all their broad use of technology already, would have the knowledge to utilize telehealth, and especially when it comes to security and the confidentiality aspects, it's just not something you can guarantee. We should be trusting that the OT will use clinical reasoning and know their own level of competency enough to know whether or not they have the training and skills to use the technology. Maybe this is something that a board would want to create regulations about. Again, though, I would want to suggest that any language be broad and not restrictive so it doesn't create a barrier to access of care. Overly restrictive language with regards to training could repel OTs from using telehealth, and that's not necessarily the direction that you'd want to go. With continuing education, I think we all know that technology changes like every day, maybe even every hour or minute of every day. And what one learned years ago in OT school about technology may not hold true today. Currently, no state has set continuing education requirements for telehealth, but this may be something to consider. If anything, OTs should be creating their own professional development plan and know that if they are utilizing telehealth, then they should include some kind of telehealth continuing education. Again, it comes down to clinical reasoning and knowing their own level of competence, but it may be good for boards to look at their continuing education requirements and whether they allow for CE that includes telehealth or whether or not it's important to mandate CE for OTs who are utilizing telehealth. And lastly, since this is an ever-changing field, there will be potentially future issues to consider for boards. This is why I like to emphasize broad language in regulation or legislation, because you really just don't want to keep going back and changing regulations every time the entire landscape changes. There are still states who have boards who have not or cannot take a position on the use of telehealth by OTs. And considering that this is a hot topic and there's a lot of people really interested in this, I would highly encourage anyone on this call who's in a state who has not taken a position to push for a decision. Like when I or an OT calls the board and asks the question, can I utilize telehealth in this state and not have any repercussions to my license, it's a bit better to say yes or no than well, we haven't even thought about it yet. When OT's licenses are at stake, it's pretty important. Nobody wants to be doing something that's going to come back for them later and potentially get their license rescinded. So while this presentation didn't go into reimbursement, because that's like another whole 8-hour presentation, eligibility for reimbursement may be an issue. We don't know what healthcare is going to look like soon. We think it may be actually in the benefit for telehealth utilization, but in reality, no one knows at this point. It's up to the feds, it's up to the states. We'll see how it goes. And while there's a lot of research out there on OTs and telehealth, there's a dearth of research on equivalent outcomes. I would also recommend that people start encouraging potentially OTD students to take a look at this for their dissertation. Could be helpful. Also, we may need to look into the monitoring of utilization to see just how many OTs and patients are actually utilizing telehealth. There's not too much research out there with that. So, for example, if only 0.0001% of OTs are utilizing telehealth, are all these regulations really necessary? I don't think it's that low. We can assume that more OTs are utilizing it than that, but it could be something that boards should look at before moving forward with regulations. All right, so that is the end of my presentation. So now we have some time for any questions. Like I said, if you did not call into the call, or call into the webinar, you can type your question in the chat box at the bottom. If you did call in, you can hit the raise hand button at the top, which is, it looks like a little person raising their hand, and we can call on you. If you have a question, when you ask the question, if you would state your name, what state you're representing, and if you're a board member or state association president, that would be great. So I'll give it a couple seconds to see if anyone has any questions. So far, no one. Really, was my presentation just so amazing? Everyone knows everything and you don't need to ask any questions? I love it. Oh, I see someone typing. All right. Thanks for patiently waiting, everyone. So Tracy Ellis has asked if we are going to send the entire slide set. Yes, this entire webinar is recorded. It will be available for download. I believe Jeremy will email it out to everyone. So if you missed the beginning, you can re-listen to the beginning. As well, you can feel free to forward it to the board, the entire board, or others who may be interested. And then Chuck, who's the Director of State Affairs and Health Policy at AOTA, would like for me to talk about how the FTC is engaged at the state level on telehealth issues and why. So the way that the FTC, and that's the Federal Trade Commission, the way that they work is they look for places, or they work to ensure that there's always competition, and they try to enhance competition. And while they don't really have the resources to actually comment on all regulations that are out there, if a state legislator asks for them to comment on something, they will do so. So, for some of it comes, well, not all of it really comes from the NC Dental Board. That's a supervision thing. But sometimes, because of that, people are asking for the FTC to weigh in. With regards to the telehealth stuff, though, really it is that regulations will come out, a state legislator will ask the FTC to weigh in, and as I said, so far the FTC has weighed in on Delaware telehealth regulations with the Board of Nutritionists and stated that the initial in-person evaluation may restrict competition and be a violation of antitrust laws. They also weighed in with Texas and Teladoc. That has to do with physicians, so more than OTs, and actually wouldn't really relate to OTs too much at all. Okay. Jimmy Himes from Colorado just wrote to me asking about broad language from AOTA. where the OT is located or licensed in the state where they are providing services or where the recipient of services resides. So with regards to telehealth and licensing, it is patient-oriented. It has to do with where the patient is located. The OT has to be licensed in the state where the patient is located, not necessarily where the patient resides. So this could be, if you could potentially have a patient who resides in Arizona, but in order to use a computer has to drive over to New Mexico. The OT would need to be licensed in New Mexico to provide services to a person in New Mexico. I hope that answers your question. Are there any other questions? All right, it looks like there isn't. So as I said, this is recorded. We will let you have access to it so that you can use it, re-listen to it, send it out to the boards however you like it. I greatly appreciate everyone being on this call. I hope this was helpful. If at any time you have any other questions or need any more information, again, here's my name and contact information. As well, when you actually get the presentation, you can click on the link. That link will take you to the State Affairs webpage, and it will have the list of documents, all the resources I talked about, the telehealth position paper, the ethics paper, as well as I had created a chart that has the statutes, regulations, or if for every state, or if that didn't exist, notes on what the state has actually done. And if you can't find them on the website, again, feel free to email me, and I will email them out to you. So thank you, everyone, for participating in the webinar. I hope you have a great evening, and good night.